I would like to call our chairperson for the next session to be seated on the dais. I like to call Dr. Vetrivel sir from Apollo KH Hospital and Dr. Rajavel sir, ex-superintendent of Government Valley Medical College, and Dr. Saktivel sir from Srinarani Hospital and Vellur, and Dr. Sriram sir, MG from Madurai. And I like to call upon the next speaker, Dr. Pavan Kumar sir, who is a senior consultant in Srinarani Hospital and Vellur.
Good morning, everyone. I would like to thank my mentor, Dr. Mohanraj sir, for giving me this opportunity. Today I am going to speak about one common problem in the community, that is diarrhea. Diarrhea is a human universal experience, but how prevalent it is in India? In AIMS, they have conducted one study combining rural and urban population, nearly 4,700 participants, and with the male to female ratio of 1:1. Abdominal pain tops in the prevalence with 17%, followed by constipation, and diarrhea is at 11%. So what is diarrhea? Is it about frequency? Is it about liquidity or fluidity of stool? Or is it about volume? Or combination of all factors? So everything is important. So what drives the frequency? We all know that rectum drives the frequency. Once stools reaches the rectum, rectal mucosa will get sensitized, and the reflex will go to the brain, and defecation reflex will start. But there is a condition where pelvic floor dysrhythmia, this is a type of functional constipation where patient will be having constipation, he will be passing small quantity stools multiple times. So frequency, increased frequency is not diarrhea always, the exceptional thing is pelvic floor dysrhythmia. So it is not about frequency always. So is it about liquidity or fluidity of stool, or is it about volume? So what drives volume or liquidity of stool? Nearly 10 liters of fluid will enter into the small intestine, starting from saliva, gastric secretions, hepatobiliary secretion, pancreatic secretion, and whatever fluids will take. Out of that, nearly 6 liters will get absorbed in the small intestine jejunum, 2.5 liters in the ileum, only 1.5 liters will enter into the colon. Out of that, 1.4 liters will get absorbed in the colon, only 0.1 liters will get excreted in the form of stool. So nearly 99% of fluid will get absorbed in the intestine, both in the small and large intestine. So even 1% change in the absorption also will lead to diarrhea. So what drives volume or liquidity of stool? So more volume will be seen in acute diarrhea, mostly in infections. Obviously malabsorptive syndromes will have large watery diarrhea, and secretory conditions also will have watery diarrhea. But in small intestine, generally small intestinal diarrhea will be large volume. But there is an exception, because colon will act as a savior. If small intestine is a problematic but large intestine is working properly, in that situation colon acts as a savior and it will absorb the most of the volume. So small intestinal diarrhea, always it is not large volume. So to call it as a diarrhea, more than 3 stools per day, and volume should be more than 200 ml per day, and out of that most important is the Bristol stool chart. Type 1 to type 7 is there. Type 1 and 2 are seen in constipation. Type 6 and 7 are seen in diarrhea. Type 3 and 4 are the normal variety. So more than 3 stools per day with Bristol stool type of type 6 or 7 is most important criteria to call it as diarrhea. The problem here is collecting the volume, collecting the stools in entire day and measuring, that is the problematic here. But frequency and type of the stool is very important to classify it as diarrhea. So classification of chronic diarrhea based on the mechanism, four types are there. Osmotic diarrhea, this is caused by poorly absorbed substances that draw water into the colon. This improves with fasting, examples like lactose intolerance and osmotic laxatives. Secretory diarrhea, this is caused by increased secretion of water and electrolytes. This is large volume, but this is persistent with the fasting. This is the differentiating finding between osmotic and secretory. Osmotic diarrhea, it improves with fasting, whereas secretory diarrhea, it persists with fasting. Examples like bacterial toxins and hormone secreting tumors. Inflammatory diarrhea caused by mucosal damage associated with passage of blood, pus and mucus in the stools, and a classic example is inflammatory bowel disease. And fatty diarrhea caused by defect in digestion or absorption of nutrients associated with weight loss, steatorrhea, examples like celiac disease and pancreatic exocrine insufficiency. So etiology of small bowel diarrhea are divided into mucosal phase, luminal phase, and transport phase. In mucosal phase, malabsorption like celiac, tropical, and parasitic infections, Whipple's disease, IPSID. IPSID is immunoproliferative small intestinal disease, immunodeficiency, Crohn's disease, and tuberculosis. Tuberculosis is not a common cause of diarrhea. Nearly 20% of the patients with tuberculosis only they will present with diarrhea. So tuberculosis is not very common for diarrhea. And in luminal phase, chronic pancreatitis, bile acid diarrhea, and small intestinal bacterial overgrowth. In transport phase, abital hypoproteinemia and lymphangiectasia. Infections causing diarrhea, mostly will be seeing parasitic infections for chronic diarrhea, giardiasis, Enteromoeba histolytica, strong allied cryptosporidium and cyclospora. Crypto and cyclospora will be seeing in immunocompromised patients. And bacteria, Clostridium difficile. Clostridium difficile generally will be seeing in hospitalized patients, patients who are on long-term antibiotics or patients with the inflammatory bowel disease, followed by E. coli, Campylobacter and Salmonella. In viruses, generally immunocompromised or inflammatory bowel disease patients, post-transplant patients commonly will be seeing cytomegalovirus. Other viruses like adeno and rotavirus are very rare. So in etiology of large bowel diarrhea, mostly functional diarrhea will be there, followed by inflammatory bowel disease, microscopic colitis, infections, mesenteric ischemia, radiation colitis, even neoplasia also can present as chronic diarrhea. So I'll start with one case scenario that I have seen in my OPD recently. 61-year-old male, he presented with increased stool frequency for 4 months, 6 to 8 episodes per day, small quantity, Bristol type 5 to 6, frequent blood mixed stools not associated with abdominal pain. Patient had loss of appetite and a significant weight loss of 7 kgs in the 4 months. He don't have any comorbidities and no history of any addictions. So how to approach this case? There are 7 to 8 steps in approaching chronic diarrhea, whether the diarrhea is acute or chronic, functional or organic, small bowel or large bowel, volume and content of stool associated with malabsorption or not, whether it is painful or painless, associated with bleeding or not, whether it is inflammatory or non-inflammatory. First step is whether diarrhea is acute or chronic. Acute is less than 2 weeks and chronic is more than 4 weeks. Whether it is functional or organic, functional diarrhea will be long duration and without any constitutional symptoms. Exaggerated gastrocolic reflex and long duration of diarrhea favors more towards functional. Whether it is small bowel or large bowel, in small bowel frequency will be less than 4, large volume stools will be there, and in large bowel frequency will be more than 4, small quantity, presence of blood, mucus and pus indicate large bowel diarrhea. Volume and contents of the stool, large volume and watery, it will be secretory diarrhea, acute or neurohormonal secretion related. If the large volume but the content is solid stool means frothy, sticky, generally seen in malabsorptive syndromes. So whether patient is having features of malabsorption, carbohydrate malabsorption, they will present with generalized weakness, bloating, flatulence and barbogamy. Fat, loss of body fat and steatorrhea, low BMI and low trifold skin thickness, that will indicate loss of body fat. Protein, loss of somatic and visceral protein. Somatic protein is muscle mass and visceral protein is the low albumin levels. Features of vitamin deficiency, thiamine deficiency present with beriberi, neuropathy, riboflavin deficiency, glossitis, angular stomatitis, niacin deficiency with diarrhea, dermatitis, pyridoxine anemia, folic acid and B12 deficiency also present with anemia. Inflammatory or non-inflammatory diarrhea. Most 2 common findings in inflammatory diarrhea is present of fever and joint pains. Typically we will be seeing in inflammatory bowel disease, in some case of tuberculosis, IPSID, Whipple's disease and eosinophilic enteritis. Whether diarrhea is associated with pain abdomen or not. Presence of colicky pain in a chronic diarrhea patient, that indicates stricture in the abdomen like in tuberculosis, IBD and IPSID. Generally chronic pancreatitis patients, they will present with pain. They won't present more about diarrhea, but if we ask the history, they will say yes, they are having oily stools. Whether diarrhea is associated with bleeding or not. Generally presence of blood in stools indicates there is ulcer somewhere in the GI tract. Classically, we will be seeing in inflammatory bowel disease, some patients of TB and colonic malignancy also present with bloody stools. So, compiling all the clinical information to our case, patient was a 61-year-old male with 4 months duration of diarrhea, large bowel type because more than 4 episodes present with blood. It was organic in nature, there are no features of malabsorption, it was painless diarrhea, blood was there and no inflammatory features. So, many red flag signs are there like presence of blood, loss of appetite and loss of weight. So we need to evaluate the patient aggressively to diagnose the organic condition. In the same way, second scenario, like an example, 45-year-old male patient with diarrhea for 3 years, large bowel type, functional in nature, pain is there often, no blood, no inflammatory features. In this scenario, it will fit into functional bowel disease like IBS, irritable bowel syndrome. So how to evaluate the patient after 7 to 8 steps of history and investigation? Principles of investigation that depends on the differential diagnosis based on clinical evaluation to assessment of effect of disease, test of structure and function, and etiological evaluation. Basic lab test in patients with chronic diarrhea, blood test like complete blood count to check for whether there is any presence of anemia, comprehensive metabolic profile like thyroid, sugar test. If at all we are suspecting celiac disease in a malabsorptive syndrome patient, we can check for IgA, TTG antibody, C-reactive protein as a marker of inflammatory disease, and basic stool test like fecal occult blood and fecal calprotectin in inflammatory bowel disease, stool test for ova culture. And if the patient with diarrhea having features of malabsorption, we can check for malabsorptive test like D-Xelose test. This is a pentose sugar to check for carbohydrate malabsorption, and quantitative stool test, that is 72-hour stool test to check for steatorrhea. More than 7 grams fat per day is suggestive of steatorrhea, and qualitative test is stool for fat globules up to 100 globules with diameter less than 4 millimeter is normal. If the patient is having recent history of travel, more flatulence, excess Borborg-Mini, and any anatomical disturbance like a past history of surgery, diabetes, or any connective tissue disorders, in those patients, patient may be having small intestinal bacterial overgrowth. There we can go for hydrogen blood test, but the gold standard test will be small intestinal aspirate culture. So exclusion of structural disease, we have to go for imaging, either CT or MRI. Enterography will be giving the better information compared to IV contrast. Colonoscopy with mucosal biopsies. If small intestinal pathology has been suspected, we can go for enteroscopy with the biopsy. If small bowel involvement in the form of Crohn's disease has been suspected, we can go for capsule enteroscopy. So exclusion of pancreatic exocrine insufficiency, stool elastase is a sensitive test, less than 50 micrograms per gram of stool is a sensitive test to diagnose pancreatic exocrine insufficiency, but empirical trial of pancreatic enzyme replacement therapy also helpful to diagnose pancreatic exocrine insufficiency. So in our case, as patient was having bleeding PR, elderly patient, we have done colonoscopy. Colonoscopy has showed semi-circumferential ulceroproliferative growth at rectosigmoid junction. Biopsy showed moderately differentiated adenocarcinoma, and CT abdomen we have done, it has showed heterogeneously enhancing semi-annular lesion involving the rectum, and there is a solitary hypo-enhancing lesion in the liver also. That means patient, by the time he presented, he was having liver metastasis, solitary liver metastasis. So in empirical therapy of chronic diarrhea, generally in acute diarrhea mostly caused by bacterial infection. So patient will be started with empirical antibiotics or probiotics. But in case of chronic diarrhea, infection is very rare cause. So empirical therapy chance will be very less, but still there are some conditions where we can use empirical therapy in chronic diarrhea, like initial temporizing or treatment before diagnostic testing, after diagnostic testing has failed to confirm the diagnosis, and when a diagnosis has been made but no specific treatment is available or specific treatment has failed. So empirical therapy options like loperamide or diphenoxylate and resicardotil we can use in secretory diarrheas. Octreotide very rarely will be using for chronic diarrhea, like exceptional conditions like in dumping syndrome, carcinoid or chemotherapy induced diarrhea. Cholestyramine in bile acid, it is a bile acid binding regimen used in idiopathic diarrhea or in confirmed bile acid diarrhea. And pancreatic exocrine replacement therapy, we can use it in pancreatic exocrine insufficiency and in idiopathic diarrhea. So probiotics are non-specific therapy for diarrhea, and evidence of effectiveness is very limited with probiotics in chronic diarrhea, and empirical antibiotic therapy also is less useful in chronic diarrhea. Some diarrheal syndromes like IBS, that is irritable bowel syndrome, based on Rome 4 consensus, abdominal pain is the main central feature along with change in frequency and consistency of the stools. And food-induced diarrhea, poorly absorbed carbohydrates, most commonly lactose intolerance will be seen, and consumption of processed foods containing high fructose. Microscopic colitis, that is contains two parameters, the one is collagenous and second one is a lymphocytic. They are present with watery diarrhea. Colonoscopy will be normal in these patients, but if we take the biopsy, we will find the histopathology changes. Post-surgical diarrhea, if patient underwent for gastric surgery and past history of any ulcer or tumor, patient will present with dumping syndrome, early dumping syndrome and late dumping syndrome, and bowel resection, short bowel syndrome will be there. Bile acid induced diarrhea, that the causes will be either because of ileal resection or ileal dysfunction and post-cholecystectomy and congenital transport defect. Anything can cause bile acid induced diarrhea. The diagnosis is very difficult and availability of test and feasibility. Fecal bile acid output in 48 to 72 hours in timed stool collection is the one of the tests we can use, but availability is the problem. Best thing will be empirical trial of a bile acid sequestering resin to diagnose the bile acid diarrhea. So frequent diagnosis in patients with diarrhea of obscure origin like bile acid induced diarrhea, carbohydrate malabsorption, fecal incontinence, functional diarrhea, drug-induced diarrhea, IBS, microscopic colitis, pancreatic exocrine insufficiency, bacterial overgrowth and excessive use of laxatives. So red flag signs in chronic diarrhea, loss of appetite, loss of weight, nocturnal stools, anemia, bleeding PR, mass per abdomen and family history of GI cancers. If any of these red flag signs are there, that means patient is having some organic problem and we have to evaluate the patient aggressively. So to summarize my presentation, chronic diarrhea requires a step-by-step approach. History is a powerful tool about stool characteristics, diet and red flag signs that will lead us to the proper diagnostic approach. Order your investigation strategically. Don't do all tests at once. So initially do the basic blood test, stool test, followed by based on that we can go for second level test. And management is tailored to the specific diagnosis.
Pavan, that was wonderful. I think you have covered everything. And diarrhea is one of the commonest symptoms that we see as a clinician. And once it is mixed with mucus or blood, we have to give more importance. And if there is a family history, certainly we have to give more importance. And routinely we see a lot of viral diarrheas in the society. That is one. One point I would like to mention about this hyperthyroid. There's a terminology called diarrhea. Okay, so that is actually a hyper defecation. So you don't see as diarrhea is defined by WHO as passing more than 3 watery stools per day. Okay, you don't get that in because in hyperthyroidism you get only motility. There's hypermotility. Okay, unlike this, just for the sake of postgraduates, there's only hyperdefecation, hyperthyroidism. That is an information. And otherwise, I think you have covered everything, and where we should give importance and which patients we should work up, I think you have highlighted. Well done.
A couple of questions. The abdominal ultrasound proves to be colitis.
Yes, sir.
What is the antibiotic? Is it rifaximin is going to help you?
Sir, rifaximin is a luminal selective antibiotic. It is not going to get absorbed into the system. We can use in small intestinal bacterial overgrowth, even in patients with inflammatory bowel disease patients we can use. Traveler's diarrhea we can use. If it is systemic infection presenting with diarrhea, rifaximin is not going to help, sir. Only luminal infection, it is going to help rifaximin.
Loperamide.
Sir, loperamide has been any person or any patient gets diarrhea, first he will go to the medical shop and get the loperamide. But we have to use the loperamide very cautiously, this one particularly in infection because it is anti-motility agent. The two common indications where we can use loperamide is antibiotic associated diarrhea, and in IBS, irritable bowel syndrome related diarrhea, we can use loperamide. In infections and all, we have to use the loperamide very cautiously, that too along with antibiotics. Because of antimotility, whatever toxins volume has been secreted into the lumen, it will be stored in the lumen because of reduced motility secondary to loperamide, and it can lead to megacolon and complications.
Yes. Thank you.
Pavan, it was a crispy presentation. Congratulations.
Thank you. Thanks.
My question is that to differentiate between osmotic diarrhea and secretory diarrhea, are we doing stool osmolality routinely in our hospital?
Routinely, we are not doing such small osmotic gap. Generally, we will ask the history in osmotic gap. Generally, lactose intolerance or high fructose containing things, fructose corn syrups, they will be presenting with our patient taking any osmotic laxatives, they will present with osmotic diarrhea. If any particular food item is giving diarrhea, and after stopping that food item, if patient is responding, means based on that history, we can diagnose it as osmotic diarrhea.
How about this hydrogen breath test and all?
Hydrogen breath test, it is available in our hospital, sir. We are doing, sir. For small intestinal bacterial overgrowth, we are doing, sir, in our hospital. There is a patient with excess flatulence, Borbog mini, more bloating sensation, any recent history of travel, and patient with the past history of any surgeries, altered anatomy, diabetic patients, and any history of connective tissue disorders. In those cases, patients, there is possibility for small intestinal bacterial overgrowth, and this one hydrogen breath test we are doing, sir. We'll, after that, if we give the antibiotics, 2 courses of antibiotics with a gap of about 2 weeks, patients are responding very well.
Is there any differential diagnosis for chronic diarrhea? As I mentioned already, hyperthyroidism, it's called pseudo-diarrhea, I think.
So,
Thank you for this informative and knowledgeable session, sir. So